Hello friends, welcome back to another video where I'll be discussing about congenital myasthenia and Lambert Eaton myasthenic syndrome. Congenital myasthenia are actually a group of neuromuscular junction disorders which are caused by genetic defects in the muscle end plate molecules which are involved in the neuromuscular transmission. So, basically, it's a disorder of the end plate molecules, right? And these most of these congenital myasthenia are autosomal recessive, right? And excepting a very few, one is the slow channel syndrome, which is autosomal dominant. Slow channel syndrome is autosomal dominant. Rest all the congenital myasthenia syndromes are autosomal recessive. And these congenital, as the name indicates, they are congenital, means they are present in the infancy or childhood, but very rarely they can have presentation in the adulthood also, so that you have to be careful. But remember, if a child presents to you with myasthenia gravis, definitely you keep in mind congenital myasthenia syndromes. So we'll take a look about what are the molecules which are deranged or which are defective in patients with congenital myasthenia. Now, this is a review of the previous thing which we learned in myasthenia gravis. We know that with the help of this enzyme which is known as choline acetyl transferase, and this enzyme is present presynaptically. So one way of classifying congenital myasthenia syndrome is that we can have presynaptic synaptic disorders are, again, because this is an enzyme defect, this is autosomal recessive. And the what is the characteristic feature in these patients is that it's usually very severe, and they usually present with respiratory failure at birth. And they actually, even though they are very severe at birth, but as the age increases, there is improvement, right? So there is an improvement with age in patients with presynaptic disorders affecting the choline acetyl transferase enzyme. Then another group of disorders is a synaptic disorders, which is caused by deficiency in the enzyme which is known as acetylcholine esterase. Now, you might be thinking that how can this really cause myasthenia gravis? The reason is that there is more of after discharges which occur on this due to deficiency of this enzyme. More of acetylcholine is present in this synaptic cleft. So more of acetylcholine in the synaptic cleft really leads to more of sodium influx into the sodium acetylcholine receptor, that is a sodium channel, and this leads to after discharges. So really speaking, these patients usually will have other associated features. You will have myasthenia, but the other associated features will be like they will have some skeletal muscle abnormalities like scoliosis. Okay, there will be scoliosis, and there will be also, these patients may have axial weakness. They have axial weakness, and they can have extraocular muscle involvement. And one characteristic feature which has been asked multiple times in the exams is that in patient with acetylcholine esterase deficiency, you have absent slow or absent responses. So if you do the light reflex in these patients, slow or absent pupillary responses. This is what you need to keep in mind. So patients with acetylcholine deficiency have slow or absent pupillary responses with skeletal abnormalities like scoliosis and muscle abnormalities including axial weakness. And as I have told you, they are autosomal recessive. And another thing is that they have variable severity in these patients. And if you do the nerve conduction, again, because there is prolonged opening up of this channel is remaining open for longer period of time, means you get after discharges on the nerve conduction studies. So this is a very typical of congenital myasthenia, if you get after discharges, there are only two differential diagnoses. One is acetylcholine receptor, acetylcholine esterase deficiency, or another thing is one is acetylcholine esterase deficiency, another is a slow channel syndrome, which is a post-synaptic form of congenital myasthenia. Let's discuss it together. This channel is actually a voltage, first of all, it is a ligand gated sodium channel, okay, and this remains open only when acetylcholine binds to it. Now, what happens in slow channel syndrome? This channel remains open for prolonged periods of time, right? That means it is slow to close. The slow means it is slow to close. That means that is a large time when it remains open. So since it is open for a longer period of time, more of sodium enters into this postsynaptic membrane. So more of sodium again after discharges. So this two differentials you need to keep in mind. After discharges in repetitive nerve stimulation or decremental response, plus after discharges, we have already discussed in myasthenia gravis that there is a decremental response. If there is a decremental response on repetitive nerve stimulation along with after discharges, then there are only two things. One is a acetylcholine esterase deficiency or a slow channel syndrome. Another thing, in the postsynaptic group, we have primary acetylcholine receptor deficiency. So this is just like you have autoimmune destruction in patients with myasthenia gravis, but in congenital myasthenia there is a primary deficiency of the acetylcholine receptors. So this is primarily due to a defect in the acetylcholine receptor genes, and mostly it is the epsilon subunit which is usually mutated in these patients. That's the most common form of congenital myasthenia, and we have already discussed the slow channel. Another group of this channel, if it is defective, is a fast channel syndrome. So what is this fast channel syndrome? As I was telling you, there is the prolonged opening in cases of slow channel. Here this channel kind of closes very fast. It closes very fast. So what happens? There is the rate of the decay of the end plate potential, the rate of the decay. So if you look at the end plate, means immediately. If it opens for a short period of time and then closes immediately, so that's why you call it a syndrome, because it closes very fast. So RNS here you never find after discharge because sodium is not entering the postsynaptic end plate, so therefore of sodium entering, and you don't get these after discharge. Fast channel, you only have the decremental response to repetitive nerve stimulation, but slow channel you have decremental response plus after discharges, right? Now there are other these proteins which are actually responsible for aggregation of these acetylcholine receptor in the postsynaptic end plate. They are DOX7, agrine, LRP4, rhabsin, and MuSK. Okay, these four proteins can also have these genes can be mutated, and we can have defects leading to congenital myasthenia. Of these will have decremental response on the RNST. So decremental response on the RNST. So this is a very gross organ myasthenia where I have divided them into presynaptic, synaptic, and postsynaptic. Presynaptic is the enzyme defect, that is the synthesis of the cholinesterase transferase. Synaptic is due to acetylcholine esterase deficiency, which is causing more of acetylcholine to stay in the synaptic cleft, and the postsynaptic can be due to the receptor defect, or they can be due to aggregation of the receptor defect. Receptor defects are either fast channel, slow channel, or primary acetylcholine receptor deficiency, or the aggregation defect, that is DOX7, agrine, LRP4, and rhabsin and MuSK. Right now let's have a look at the comparison with all the three in one table. This helps you to memorize faster. Now, presynaptic we have discussed. It is due to cholinesterase transferase deficiency. The gene is the same, and as I told you previously, it is mostly associated with respiratory failure, and as expected, because there is less of acetylcholine which is synthesized. If you give acetylcholine esterase inhibitors, more of acetylcholine will be staying in the synaptic cleft and there will be good response. If you look at the repetitive nerve stimulation studies, there will be decremental response in the repetitive nerve stimulation studies. And you can also try this drug, which is 3,4-DAP. What is this drug? This actually blocks the potassium channels. So if the potassium channels are blocked, there is depolarization of the presynaptic end plate. This will lead to more of release of the acetylcholine. So you kind of try to block the repolarization current by blocking this potassium channels. So repolarization happens by the efflux of potassium and you block that. So this drug is doing exactly the same. Now let's have a look at the synaptic defects which we have already discussed. One is the acetylcholine esterase deficiency. The gene actually here is, you need to remember, is COL-Q gene, and this with this absent pupillary responses, scoliosis, and extraocular muscle involvement can be there, so they can present with diplopia, and they worsen with acetylcholine esterase inhibitors because they are deficient. And if you give acetylcholine esterase inhibitors, definitely that is going to worsen. And on RNST, you will get decremental response, plus you will get after discharges. And these drugs can be tried because these drugs, actually if you give these drugs, they are more likely to worsen this, so you don't give. And you can give albuterol in these patients. Salbutamol in these patients can be tried, and ephedrine can also be tried in these patients. Then have a look at this postsynaptic one. As I have told you, it is one group which is due to abnormal clustering, where I have told you these 4 proteins, and there is a primary acetylcholine receptor, slow channel and fast channel. So this is due to the subunit genes. Most common is the epsilon subunit, which is mutated, and slow and fast channel all are autosomal recessive, except the slow channel one, which is autosomal dominant. This I told you in the beginning itself, that the autosomal dominant is the slow channel one. So slow channel LRP4, they actually worsen with the acetylcholine esterase inhibitors, because as I have told you, this actually is a query, because some books mention that it worsens and some books really say that it improves. But basically you remember that what worsens with treatment with acetylcholine esterase inhibitors is the slow channel and the acetylcholine esterase deficiency. And RNST will definitely show after discharges, and all others there will be also decremental response. But here in RNST there will be decremental response plus after discharges in patients with slow channel syndromes. And in slow channel we have a drug which blocks the sodium channel, because we don't want it to open, we don't want it to stay open for that prolonged period of time. So as we have read that antiarrhythmic drugs can block the sodium channels previously when we discussed antiarrhythmics, we will be talking about this. This is fluoxetine and quinidine, which are class 1 antiarrhythmics, and they are actually used in treatment of arrhythmia, but they can also be used in treatment of slow channel syndromes. Now, after having discussed congenital myasthenia syndromes, let's have a look at another disease which is a close differential of myasthenia gravis, that is Lambert Eaton myasthenic syndrome. So Lambert Eaton myasthenic syndrome is actually a presynaptic defect. This is a very important question, because the myasthenia gravis is actually a postsynaptic defect where you have antibodies against the acetylcholine receptor, and these antibodies cause, as I told, they cause aggregation, and there are blocking antibodies. There will be complement mediated destruction of these antibodies. So these are the other mechanisms, but here basically it's a presynaptic disease, and there are antibodies against this specific type of the calcium channel, which is the PQ type of calcium channel, which is a presynaptic calcium channel and is responsible for the depolarization of the presynaptic nerve terminal. So, and it, as I have told you, it's present in 85% of the patients. Just like I told you in myasthenia gravis, previous discussion of myasthenia gravis, I told you that calcium channels, that antibody against the acetylcholine receptor, they are present in 85% of the patients with generalized myasthenia. Similarly, in Lambert Eaton myasthenia syndrome, 85% will have antibodies against the PQ type of calcium channels, and they are paraneoplastic. They are associated with small cell carcinoma in the in the old patients, but in the young patients you will have that there will be no association with malignancy. It's still not known why these patients develop, but maybe an at antibody mediated destruction. What is the cause of that antibody? We don't know. So the antibody mediated destruction occurs here also, but here the antibody is produced because of a paraneoplastic response, but in young patients it's not a paraneoplastic one. It's not associated with malignancy. It will be futile in patients with Lambert Eaton myasthenic syndrome if we go for search for search for cancers. So definitely check the PQ calcium channels, but no need to really check for small cell carcinoma of the lung. And here what really is difference is that lower limb is more affected than the upper limb, and as previously we had intact reflexes in myasthenia gravis, here we have depressed reflexes, and it is associated with autonomic symptoms. It is associated with autonomic symptoms, right? And sometimes they may come to you with dryness of mouth, or they may have impotence. So that can be the autonomic symptoms. Postural hypotension can also be there, and they can also present with the they usually present with this ptosis and extraocular muscle involvement, plus usually present with this, and you do an examination, you find depressed reflexes. So your diagnosis, provisional diagnosis, is LEMS. And if you do a repetitive nerve stimulation in these patients, their very typical response is that at 2 to 3 hertz, it will be similar to myasthenia gravis, the decremental response. But if you go frequency at 20 to 30 hertz, you get an incremental response. So a decremental response at 2 to 3 hertz and incremental response at 20 to 30 hertz is virtual diagnostic of LEMS, and along with these symptoms, of course. And treatment is pyridostigmine and 3,4-DAP, obviously, because even if it is not depolarizing, even if it is not, if you kind of block the enzyme which is degrading it, more of acetylcholine in the synaptic, therefore muscle power, muscle activity. So that's how you treat these patients, pyridostigmine and 3,4-DAP, obviously, because it will prevent the efflux of the potassium and will lead to depolarization of the presynaptic nerve terminal. So thank you very much. If you like this video, please give it a thumbs up, and please subscribe to my channel for further videos like this. Thank you very much.